Hello, my name is Dr. James R. Golding, and you're watching A Natural Healthcare Alternative, the program dedicated to your health, longevity, and well-being. If there was ever a show that you should hit the record button on, I would stop and do it now, because you're going to pick up a tremendous amount of information tonight. The topic for our program today is care evaluation and self-treatment of neck, shoulder, and mid-spine and arm problems. Stay tuned. We'll be right back.
These kids are in trouble. They're not getting high on drugs or stealing. If they were, you'd do something about it right now. But why is it almost half of all parents who suspect their child has a problem learning wait a year or more before getting help? Why? Kids with learning disabilities are smart. They just learn differently. Call now. The sooner you get help, the better the chance your kid has.
Welcome back. With me today is my partner, Dr. Kenneth Kirsten, chiropractic physician and sports injury specialist, also referred to around the office as the Stretchmeister General. He'll be demonstrating our evaluation, care, and your self-treatment at home. Also, as our demonstrator model today is Ms. Lucy Perella Francis, a friend of mine and a long-term patient at the office who has graciously donated her time for educational purposes. Many of us suffer from restricted range of motion of the neck, shoulder, into the mid-spine. We get that mid-spinal pain, that stabbing into there, radiating pain, numbness into the arms and upper extremities. These can be caused either by postural abnormalities, work injuries, having some type of sprain, strain, tension, underlying spinal curvature, numerous reasons why we develop pain, bad posture into the involved area. It doesn't necessarily always take a trained healthcare professional for you at home to help yourself get rid of these tensions and tightnesses in the area. By watching this program tonight, you will have a greater understanding of where the origins of your pains and restrictions in these areas may resolve, how to go about addressing it, and how to proceed from there. And what you'll find is most of it is conservative at-home treatment. Dr. Kirsten, you want to start by breaking down the essentials for us today?
Sure. As Dr. Golding mentioned, there could be a numerous amount of complaints a patient come in to with the office. And actually, this is probably the second most popular complaint that we receive besides sciatic neuritis and low back pain is neck pain and pain into the upper extremity in some region. Now, that can be either carpal tunnel, shoulder impingement, a disc problem in the neck, many things. And that's the first thing we have to evaluate is where is this pain coming from and what is causing the pain, and not just treat the symptoms or the signs like pain into the shoulder. We don't just treat the shoulder. We have to find out where is this pain originating from and the causes of it. So after taking a comprehensive history and doing a thorough examination, we can limit or focus in on where the causes come from. For example, if a person comes in, they say they have tingling in the hand. Now that could be anywhere compression from the wrist, elbow, shoulder, and neck, and we have to discern between that. A person could come in and say, I have just pain on range of motion in my shoulder, and that could be just a pure tendonitis, a bursitis problem in the shoulder itself, or it could be coming directly from the neck. And finally, a person can come in and say, I have neck problem, neck pain, pain when I turn my head and I have cracking in my neck or noises coming from my neck. It could be a problem that originated from the shoulder that led to the neck, or just an inherent neck problem, arthritis, things of that nature. So what I'm going to do is I'm going to take you through basic examples of each condition and ways that we can discern between neck, shoulder, elbow, and hand pain, and then give you the treatment and recommendations that would be appropriate for those conditions.
All right. Well, how are we going to start? We're going to start by working from the cervical spine down, or do you want to work up from the most distal part?
It really doesn't matter. Usually when a patient comes in they address the area of complaint, I always address that area. So for example, if they have a hand problem, just purely in the hand, I'll obviously look at the hand, take possibly an x-ray, but through history and exam I have a good idea already what's going on through their symptoms. Most of these injuries are non-traumatic. their overuse. So a common thing would be a person that has a desk job, works at their desk, and they're on the computer all day. Hand pain, hand on the mouse, pain that radiates up into the elbow. So I'll do an exam of that nature, checking wrist and actually innervation or tingling, looking for carpal tunnel syndrome first. A big misnomer is people say, I have carpal tunnel pain, and I have pain in all my fingers and in my pinky finger in here. As soon as I hear pinky finger and ring finger, I know that it's not purely carpal tunnel, because it's anatomically impossible, because the nerve that innervates or goes through the carpal tunnel only innervates or involves these three fingers.
I think
so that's right away we know.
That's a vital piece of information.
That's right away we know if it's carpal tunnel or not carpal tunnel. That's boom, right there. So I will do an exam of, looking for those discernible patterns.
Mm-hmm.
And then we'll work our way up, finally, working into the spine.
Yeah.
If it's purely a neck pain, we'll just look at the neck pain and see if we can elicit any symptoms down the arms that the patient may not even be aware of they're having.
Right.
So you can go either way, but regardless, we look at the whole kinematic chain, neck to arm.
Right. What I've been observing over the course of the past few years is the fact that it used to be, before the advent of using the computer as much, people would come in and they would have an isolated problem. They would have carpal tunnel, they would have tendinitis, they would have bursitis of the shoulder or frozen shoulder or capsulitis. Frequently with these holding patterns, what we're seeing now is an overlaying of not just one of the conditions, but two of the conditions together.
Yeah, we call that double crush.
Yeah.
It's called double crush syndrome. And just like you were giving an example of the rounded shoulders and hands here, you could develop a posture in the hand which causes compression at the wrist involving the carpal tunnel, or it could be compression up into the trapezius muscle, which is very, very common just from posture, developing hypertonicity or tightness in this muscle, allowing the head to fall forward, anterior head carriage, actually causing compression of the nerve here. So you have compression here and compression here. So you can just have purely carpal tunnel symptoms, but if you don't evaluate or look up into the neck, you'll never get the carpal tunnel better. That's why some people say, oh, I've had carpal tunnel surgery, I've had this, I've had rehab, but that's not the only sole area of compression. There's multiple areas of compression. It's called double crush syndrome. Neck, shoulder, hand, elbow. So it's important to discern that too. So.
Okay. Well, let's run through our evaluation of the involved areas and give everybody, things to do, homework.
Okay. Real quickly. We could talk about each condition forever, so I'm going to basically go through a couple key factors what I look for in an exam in establishing where the problems are coming from. First, I'll have the patient even just sit here, and we'll go through ranges of motion of the neck. So if I have the patient, Lucy, just turn your head to the right, and they just complain of localized neck pain, I'm saying, okay, could be just localized neck pain, arthritis problem here. Turn your head away. Now she does this, and now if she elicits or gives pain that says, oh no, I have the pain that it reproduces. It's the same pain I have that goes into my shoulder. I know now that I'm concerned that there could be disc involvement. You can straighten your head out. It could be disc involvement. It could be a bulging disc. It could be purely arthritis compressing, or the joints being closer together, compressing on the nerve as it exits here. Or it could just be the muscle spasm and trigger points we find in the trapezius muscle. So I'll start with that, and I'll start testing that. So if I turn the head this way, and I'll compress down to accentuate that, and she elicits or says, I have that reproduction of pain all the way down to my finger, I know there's compression up in the neck. So what I want to do now is I want to reproduce and go down and see if I can elicit pain or symptoms into the wrist by doing wrist maneuvers or compression. So I'll have Lucy put your hands together like you're going to pray, and you're going to push your hands together real tight, and then you're going to bring them down, push down. There you go, just like that. And now if she says that I have pain that radiates into my fingers, in these first three fingers, then I know she has some wrist compression involvement. So I know I need to treat both wrist and neck. If she does this and she doesn't have any symptoms at all, so no, it's fine. And then she could reverse her hands and go like this, a reverse prayer sign, and go up and push your hands together. Good, and push your hands together, and still doesn't elicit any pain or discomfort. I know then the problem is coming purely from the neck or solely from the neck, and we'll treat the neck. You can relax your arms. So I won't even, worry about, dealing with the hand at that point in time, and we'll treat the neck. Now we can look at purely shoulder pain. Shoulder pain comes out, and I'll test all the muscles of the rotator cuff. Very common injury that we have here is rotator cuff, tendinitis, tendinopathy, bursitis, things of that nature. You don't have to be a pitcher to have rotator cuff problems. A very, very common occupation people have rotator cuff problems are mechanics, because they're underneath the car and they have their hand over their head all day. Okay, so that's overuse and impingement. Just having your hand up in the air for a period of time is considered overuse. You do not have to do repetitive activity as throwing or overhand athletes. So just by doing repetitive activity every day and having your hand up in the air, you can develop a tendinopathy, bursitis, rotator cuff impingement syndrome, and even tears of the rotator cuff. So we'll have to evaluate and do all the proper muscle testing of the shoulder by doing resisted testing to see if there's any weakness in different shoulder ranges of motion, and in and out, pushing in and out. And I'll know which exactly muscle is involved in that, which are 4 muscles of the rotator cuff, which we'll get into in the rehab portion. Also, another common symptom is the tingling we have into the arms with just positional change, like driving, hand up on the wheel. As soon as I get my hand up on the wheel, doc, my arm goes asleep. Okay, again, I'll evaluate hand, neck, but a common thing with that is compression of the nerve as it goes through the shoulder area. We call this area, or the nerve bundle, called the brachial plexus. These are the nerves that innervate all the muscles and fibers of the upper extremity. So what happens is a person that has their arm up has tightness in the pectoralis minor muscle, the muscles of the trapezius, the muscles surrounding the rotator cuff, can cause direct compression of the nerves out in the shoulder area, not from the neck, but out here. And they get that tingling upon position change. And we check that by doing different positions of the arm. I'll have you bring your arm back like this, turn your head away. We're compressing all the musculature in the neck, the anterior scalenes here, and usually people say right away, within 2-3 seconds, they're getting numbness and tingling in their hand. And actually, sometimes I can even feel the pulse decrease. It's so severe. I'll have them turn their head this way, and now they're better or worse. So I know there's neck musculature involvement here. Same thing, I'll bring the hand out here and slowly raise it up. I'll compare side to side. On the left side, I feel pulse decreasing right away at this level. And at this level, she starts to get numbness. So I compare sides, and this side, she can go all the way up without having any discomfort at all. So I know to do rehab and stretching of these muscles in the shoulder girdle area.
What about nerve tractioning? Frequently people say, "Oh, I got a pinched nerve in the neck. It's radiating a pain in the arm." Is the tension and tightness that occurs in the scalene muscles and up into here, can that cause neurological symptoms too? Meaning, how would we make it so that our viewers can understand that a nerve can be pinched through being overstretched?
Yeah, that's what I was getting into with the thoracic outlet syndrome, or TOS. And it has to do with just these nerves that come out of the neck, and if there's no problem in the neck, the nerves are very superficial here, and they run underneath the musculature here and the tendons. So when a person has a long-standing tension of the neck in this direction, God bless you, when it has a tension in this area, that's a long-standing compression or traction of that nerve, and it's causing that tension in there and irritation. So we know that we need to, balance the neck out and do strengthening this area and loosen up the muscles in this area. Maybe not do stretching or traction to this side, but do some stretching and traction to this side and rehab and strengthen the muscles on this side. And that can cause long-standing nerve compression and nerve damage. But it's something that can be easily achieved through just alterations of posture and exercises at home, and sometimes that's all you need. So it can be something that seems very, very significant and severe to something actually very simple by just making some modifications at home. Right. And again, this is only after a complete and thorough examination. We want to rule out disc herniation, significant problems, even disease processes. There's many things that can cause all these symptoms, but you have to focus on it and not just treat your symptoms. You have to treat the causes.
Yeah, the onset of many of those disease or degenerative processes that occurs to the joints of the cervical spine can be eradicated through doing appropriate stretching, which we're going to be doing coming up. When people come to see us in our office and we do imaging of their spine, frequently we have a lot of underlying osteoarthritic degenerative problems. But by doing these, this is like dental floss for your neck and for your back. To do these is going to prevent that yet disease, meaning what you don't have yet, but you're going to get unless you do these simple things that Dr. Kirsten's going to go over.
Okay. Now, after we've diagnosed Lucy with one of those conditions, we're going to instill a rehabilitation program, which is probably the most important part of this whole process. After doing the correction, we need to strengthen and maintain flexibility. I'm a big fan of flexibility. Once flexibility is established and maintained, you're pretty home free, and you're limiting the injuries that you're going to incur with. So what we need to do is, first, we're going to hit on one of the muscles that are the most common muscles and most people can appreciate tension in, the trapezius muscles. The trapezius muscle is a muscle that runs up from the base of the skull through the shoulder, through the mid-spine. These are the muscles that you always feel the tension in when you feel stressed, and the people that sit at the desks. And these muscles are always tight. And I can get onto a patient here and palpate and feel the knots and all the tender points throughout the trapezius muscles. And I know it's a trapezius muscle when I test is when I turn the patient's head away and stretch this way, and they feel that pain just radiating from the base of the neck and down into the shoulder region. So we're going to give Lucy stretches to do at home. And this is how she's going to do it. She's going to incorporate a true passive stretch or some proprioceptive stretching, which we can hopefully duplicate from what we get in the office. So what you're going to do is you're going to hold underneath the chair with one hand, just like this. The other hand's going to go over your head, bring this other hand over your head, and resist on this side. Now what she's going to do is she's going to do an isometric contraction first to stimulate the muscle and cause tension in that muscle. And then we're going to shut it off and relax it and stretch it. So what she's going to try to do is she's going to actively bring her head into her hand and doing a neutral isometric resistance, which means she's contracting the muscle without changing the length of the muscle. So she's holding for 10 seconds, and after 10 seconds, she's going to relax. She can exhale, close her eyes, helps muscle relaxation, pull over, and lean away as you're holding on. The key factor here is leaning away with the traction, and you could feel that traction. It feels really good and stretches here. 10 seconds. And then she'll come back up to neutral again and resist again. Count through 10, and exhale, relax, and then she's going to go a little further this time, increasing her flexibility. Good. And if the patient has equal tension on both sides, I will have them do 3 times on this side, and then she'll reverse and do 3 times on the opposite side. If a patient is purely symptomatic on one side, I'll have them do 4-to-2 ratio. You always stretch both sides. You always rehab both extremities. You never just work on one side or the other. You always have to incorporate both sides. We can do alterations to this for the anterior scalene muscles and the suboccipital muscles in the back. So it's the same process. It's just changing angle of resistance and stretch. So what she can do is hold on again here, and then she's going to put her hand over her head just like last time. What you're going to do, Lucy, this time is you're going to kind of on an angle forward and down in a resistance this way, and then she's going to hold for 10 seconds, exhale, relax, and pull backwards and obliquely to stretch the anterior part of the neck here and lean back. And she'll feel that pull right in through here. Okay? And she'll do that again, 3 and 3. And then she can alternate and just change angle again, go backward and obliquely, resistance. And now she's going to hold for 10 seconds and then lean forward and lean away. And you'll have very subtle differences in those movements, but you're going to involve and stretch all the musculature in the neck and shoulder area there. Good. Okay. That's one. Okay. Now, what we can do is move to a strengthening exercise for this area. And this is at the final part of the neck shoulder area. And this is the most common thing, and this is a big problem that we see in society today is posture at desk. People have sitting jobs. Most of the population's sitting at the desk or sitting for hours at a time. So what they do is just stand up for a second, Lucy. We're going to switch chairs here. Can I do this here? Change sideways. Sit down. Most people have a tendency to round their shoulders out and jut their neck forward. Okay? Now, every day they're looking at the computer, and what happens, very good typer, and what happens is that after weeks, months of doing this, there becomes a muscular imbalance, and that's how pain starts. People say, I come in and I don't know what I didn't do anything. It's a cumulative effect. It's called microtrauma. So we need to counterbalance this. We need to counterbalance the weakness in the neck muscles and the rounded shoulders. This is a poor posture. It's accentuating that kyphosis, or that curvature in the back, which most people don't want to, have happen to them in the future when they get older and they're hunched over. So we need to counterbalance that. So what Lucy's going to do is sit to the edge of the desk, edge of the chair there. And she could do this right at her desk, periodically throughout the day. But this is a strengthening exercise. This is really not a stretch. It looks like a stretch, but this is active muscle contraction and strengthening. And what she's first going to do is work on a chin tuck. Okay? What happens is she's developing an anterior head carriage here. Okay? And that weakens all these muscles here. So what she has to do is counterbalance that and accentuate that by sliding her chin backward. Good. Not rolling your chin under. It's a straight slide back. And she's going to feel a lot of tension up here and tension in here. And then she's going to accentuate out again and then back and hold. Good. And she's going to do this for at least 15 repetitions, 3 sets. Now she's going to incorporate shoulder blade, upper back movement along with this. So what she's going to do with this one is she's going to put her hands straight at her side, turn your palms outward, really extend, really try to point your thumbs back, and what you're going to do is, all you're going to do is squeeze your shoulder blades together. And with very subtle movements, you can feel a lot of tension and working of those muscles in this area. And relax, and she's going to do that 15 times for 3 sets. Now the big one we're going to do now is combine both. This is tough, okay? But you're going to do the chin tuck with the extension back. At the same time, she's going to take a deep breath in, okay? And this is to do with all stabilization and muscle firing patterns and strengthening. So what she's going to do is all at the same time, if she can do it, what she's going to do, I'll do it first, Lucy. I want you to do this type of pattern. You're going to chin tuck, splay out and back, and then out and let it relax. So she's going to do it. Ready? Chin tuck, splay the hands down, outward, chin tuck, breath in, and then out and let it relax. Good. And she's going to do that 15 times, 3 sets. Now also, you know, when I say 15 times, 3 sets, you want to do this to your comfortability too. You want to set a goal for yourself, but you want to try to get at least 10 to 15 repetitions on these exercises. Okay? Good. Now we're going to move on to shoulder. Okay, now we're going to get into the rotator cuff, very, very common problem. So there's a foolproof plan for just rotating any type of, or rehabbing any rotator cuff injury. It could be used for pitchers, everyday athletes, people that sit at a desk. First thing we want to do is, after we establish it's a rotator cuff problem or a weakness or a partial tear that requires conservative treatment, we want to establish range of motion. So first thing is very, very easy to do. A person can start even like after a surgery, even if they had a surgery, is do something we call pendulum exercises or Codman exercises. It causes a traction and gets you some range of motion in the shoulder. You could easily do this at home. You have a 5-pound dumbbell or a paint can. We could use any type of just weight that you need here. So she's going to lean forward, put one hand here. This is the shoulder we're exercising. She's going to let the weight traction the arm, and she's going to do gentle, gentle circles in a clockwise manner, and then she could do it about 30 times nice and easy, and then she could slow down and then start to go the other way. This will cause traction to the shoulder, remove some gentle adhesions in there, and just establish a nice traction and a range of motion into the shoulder. After she's established range of motion and she's getting good range of motion and we're ready for strengthening, there's 4 basic exercises and 4 ranges of motion we're going to do for a rotator cuff. And it works for any rotator cuff injury. The first one we have to work on is this scapula stabilization and the shoulder. So what she's going to do is going to lean forward again, put one hand here. She's going to tuck this arm at the side here. This is familiar. People have worked in the gym, a tricep kickback. But what she's going to do is everything is going to be done here with very, very limited weight, 1, 2, 3, up to 5 pounds maximum. She's going to keep this shoulder tucked in. I tell people to roll a towel and tuck it underneath the arm so they're squeezing the shoulder blade in and retracting the shoulder blade. And she's going to do a gentle, straight motion back and extension. And these are painfully slow, very, very slow exercises. Back, and again, about 3 sets, 15 repetitions. Good. Then she's going to stand up, turn this way. We're going to work on internal, external rotation. Arm tucked at the side, weight here, and again it's going to be across this way, back to neutral, this way, neutral, and then she's going to work on outward, this way, and this way. And this could be done with TheraBands, bands this way, or just holding a weight. Now I usually have the patient lie down. It's the easiest way to do this first. They're going to be lying on their side and doing this, but for purposes here, these are the ranges of motion that we're establishing. And then the last one is going to be straight extension out, thumb up in about a 45-degree plane here. Not directly in front, not directly here, right in between, somewhere between 30 and 45 degrees. Thumb pointed up, never thumb pointed down. It's irritating the rotator cuff. Hair like this, she's going to take their weight, and she's going to start at her side and slowly go up just to above shoulder height, right there, and back down. And again, slowly, 3 sets, 15 repetitions. Great. Good. Now, another big problem, adhesive capsulitis, frozen shoulder, people that just can't actually physically move their shoulder. They have trouble, arthritis, many things. They can't move their shoulder. A good stretch to do this, all you need is if you're at the gym, use a pole or a doorway. Very, very simple stretch, but really good for tractioning the shoulder blade and separating the shoulder blade from the ball and socket here, getting that stretch in there. What she's going to do is come over here, hold on this with this arm, so we're going to stretch so the camera can see this way. And what you're going to do is you're going to stand directly like this. And what you're going to do, don't pull too hard because we're going to have a lot of stability here. But what she's going to do is she's going to hold shoulder height right here, a little bit higher, right there. And what you're going to do is you're just kind of lean back and sink your butt back this way, and she's going to let that stretch, and she's going to hold on just with her fingertips, not gripping with her bicep, so she can feel the traction and pulling the shoulder out this way. And this feels really good. It's causing a retraction and protraction of the shoulder blade here and causing a traction in here. Hold for 10 seconds. She's going to stand up, turn, face the elbow a little bit more, and again, the vector of force is through this way, and then she's going to gradually keep working her way around till she's almost parallel to her arm. And this will really cause some traction and movement of that shoulder girdle. And these are ways that you can do to get some mobility and flexibility in there and cause some strengthening of the upper back and counterbalance. You can relax. And counterbalance those bad or positions that we've done throughout our day. So regardless of what the conditions are, we have to diagnose first, and most of these are able to use in rehabilitation and strengthen the whole shoulder, neck, complex, and there you have it.
Awesome job with the rehab. And you know, I like this.
In a,
I like this whole
15-minute
thing
period.
of loosening up that scapular area. Many people know a lot of exercises, but don't seem to get into that scapular thing. That really gets it.
That's huge, and that's one of the major factors. When we separate that shoulder blade from the ball and socket joint, or get that retraction and protraction of the shoulder blade, that resolves a lot of conditions that people have a chronicity with, and they can't get better.
So are you saying we're letting the cat out of the bag and allowing people to get well themselves and empower yourselves?
Maybe.
Dr. Ken? Lucy, thank you very much. You were a great
Lucy.
model today. For Natural Healthcare Alternative, I'm Dr. James R. Golding. Thanks for watching.